Our next session is the Hepatitis-B Antenatal Screening and Selective Neonatal Immunisation Quality Improvement Project, improving the quality of care of women with hepatitis B in pregnancy and their babies. And I'm delighted we have a double act again. This is the day of double acts. And we have Pat Schan, who is a clinical advisor to the Infectious Diseases Screening Programme and currently project lead for the Hepatitis Antenatal Screening and Selective Neonatal Project, and working in close collaboration with the PHE immunisation team and PHE Virus Reference Department in Colindale. And she's had huge experiences in all areas of midwifery. So she is a midwife, and before she became a screening specialist midwife for 15 years, so very skilled in anything of this nature. And she's won the Royal College of Midwives Team of the Year for the work in promoting screening as a public health issue in her unit. So that's fantastic. And alongside Pat is David Green, who's known to many of the audience, I'm sure, who is a nurse consultant for immunisations with PHE's National Immunisation Team, with particular focus on improving immunisation uptake in pregnancy. The education of healthcare professionals in immunisation, vaccine incident management, and the development of patient group directions for immunisation programs. This sounds like a real juggling job, David. And his dissertation for an MPH at the University of Leeds was a dissertation on the efficacy of pneumococcal polysaccharide vaccines in the elderly. So a whole range of experience you have set before you. So welcome to Pat and David. I have to say now the screen is yours. Welcome.
Hello everybody, I'm Pat Schan, as introduced by Sue. I'm the clinical advisor and I was project lead on this, the hepatitis B. It's a great big long title, but basically it was a very collaborative project between ourselves and PHE to look at this pathway. So I thought I'd start by just checking out really about the understanding of hepatitis B. That it is a potentially life-threatening liver infection caused by the hepatitis B virus, and it is a major public health problem. We've used this slide in many presentations over the last 2 years of the project, because it just demonstrates the hepatitis and what it's doing in the world, whereas everything else is on the way down, HIV, malaria and TB. Good old hepatitis is quite firmly on the way up. So it causes chronic infection and puts people at very high risk of death from cirrhosis and liver cancer. And the likelihood is that as that infection becomes chronic, depending on the age in which the person becomes infected. So children that are less than 6 years of age who become infected with the virus are most likely to develop chronic infections. So that brings us to our cohort, which is infants, and 80 to 90% of infants infected in the first year of life will go on to develop chronic infections. But there's been a vaccine against hepatitis B since 1982, and that vaccine is 95% effective in preventing infection and the development of chronic disease and liver cancer due to hepatitis B. So the pathways, I thought we'd just talk about the pathways quickly for those of you who aren't involved in screening. So screening in pregnancy for hepatitis B is offered and recommended. Now, I think that's a really important point, is that with the infectious diseases, the 3 diseases we screen for, which is hepatitis, HIV and syphilis, we offer and recommend this in every pregnancy. And about 3,000 screen positive every year. So depending on the viral load, women screening positive are then considered to be at lower or higher risk of transmitting that infection to the baby. So obviously women with a high viral load are deemed to be of higher risk of giving the infection. So babies of women with lower risk are given the first dose of hepatitis B monovalent within 24 hours, and the babies of higher risk are given the vaccine, and then in addition they're given the hepatitis B immunoglobulin. So I've put here handover point and this little relay runner, because I think when we started the project a couple of years ago, this was one of the things, this theme that we tried to get about this kind of handover points, because there are so many people involved in the pathway, but it actually just lets me hand over to David as well. So.
Thank you, Pat. Can I just check that someone can hear me? Is it all working? It's all working. That's fabulous. Thank you. So I'm David Green, nurse consultant for immunisations with Public Health England. So once a baby is born to a mother who is infected with the hepatitis B virus, the maternity services will inform the GP practice and also the child health informatics services. And part of the reason why they tell them is so that the baby can be scheduled to receive the correct vaccines. So what you see in this table is on the left-hand column, age in weeks, and in the middle column is the routine childhood immunization program. So every baby is offered 3 doses of a hepatitis B containing vaccine at 8, 12, and 16 weeks. And this is called a hexavalent vaccine, protects against 6 different diseases, these being diphtheria, tetanus, polio, pertussis, Hib, and hepatitis B. And we introduced this vaccine into the routine childhood immunization schedule in 2017. Now, the routine program is going to protect those babies against the risk of hepatitis B should they become exposed to that virus at some stage in the future. The right-hand column is somewhat different. So this is the immunization schedule for babies who are born to hepatitis B infected mothers. And this is really, really important because these babies will have been exposed to a significant amount of virus in the perinatal period. And so this program is unique in the routine childhood immunization program, because actually what we're doing here is we're vaccinating these babies against a disease to which they have already been exposed. So the timeliness of these vaccines is absolutely vital. So at birth, all babies born to hepatitis B positive mothers are going to be offered the first dose of a monovalent hepatitis B vaccine. That means it's just got hepatitis B antigen in it. It doesn't protect against anything else. If they're at particular high risk, if the mum has a high viral load, then they are additionally given hepatitis B immunoglobulin as well. They get an additional dose of hepatitis B vaccine at 4 weeks, and then at 8, 12, and 16 weeks, they get their 3 doses of the hexavalent vaccine, just like all the babies coming through the routine program would as well. At 12 months, they're offered a final booster dose of monovalent hepatitis B vaccine. And the other thing that happens at that visit to the general practice as well is that they are tested for hepatitis B surface antigen. Now, this again is a really, really important point. The surface antigen test doesn't look at antibodies. It's done to see whether or not the baby is infected with hepatitis B. And really, it's a test of success of this program. So have we managed this baby in a way and given the right doses of vaccines at the right time to prevent that baby acquiring hepatitis B from its mother at the time of birth? So you could look at this program for these babies born to hepatitis B infected mothers as a form of post-exposure prophylaxis. Can I have the next slide, please? Thank you. This table sets out the, I think the timeliness is the important issue here, which is on the right-hand side of the key doses. The first 3 doses of hepatitis B containing vaccine are going to be vital in preventing this baby or these babies developing hepatitis B following the exposure to the virus at birth. So we've got 92% of those babies get the first dose of vaccine at birth. That's pretty good, but we would like to see it a bit higher. But what you can see there is a general trend, general downwards trend in recorded uptake. And then by the age of 12 months, you can see there that only about 2/3 of these babies are actually receiving that vaccine. So this in part is what helped to drive the need for the quality improvement project and the collaborative working between the screening team, which is where Pat is, and the immunisation team, which is where I am. So we've jumped around slightly to try and keep the presentation going. One of the things that we found when we started examining the kind of resources that we've got available, both from the screening side and from the immunisation side, in support of this programme, one of the things we found, certainly from the inside, was that we didn't really have an awful lot of information, and what little information we had was only available in the English language. So we've done a number of different new leaflets. This one that's on the slide there, which is Hepatitis B, a guide to your care in pregnancy and after your baby is born, is really a guide for those women who've screened positive for hepatitis B. So you can see the middle image there explains a bit about what hepatitis is and then what the implications are for baby. The right-hand image we thought was very important as well, because it's absolutely vital that the woman who's given birth to a baby, if she herself is infected with hepatitis B, that she understands the importance of registering her baby's birth, and in particular, prompt registration of her baby with a GP. Because 4 weeks after that baby is born, they need the second dose of the monovalent hepatitis B vaccine, and they also then need all the other subsequent doses from 8 weeks onwards. So we try to emphasize the importance of GP registration, the importance of the Red Book, which has a specific insert for babies who are born to hepatitis B. Infected mothers. Could you bring up the next slide, please? And this leaflet, again, was a new one, because when we had a look at what resources we had, we didn't really have a specific leaflet for women following the birth of their baby if they were infected, or if their mothers were infected with hepatitis B. So when we were drawing up this leaflet, and I say we, I've got to give credit to my colleague in the IMS team, Michelle Faulkner, who drew this up. She was pivotal to this, really. When we drew up this leaflet, we wanted to sort of empower women to take, to understand and take ownership of their baby's accelerated hepatitis B immunisation schedule. So you can see there that the middle image there is a page from the leaflet where either she or one of the healthcare workers caring for her and her baby can insert the dates of when the next appointments are due and when those vaccines are given. We've also had this leaflet translated into 13 different languages. I scribbled them down quickly just before this presentation. They've been translated into Chinese, Polish, Romanian, Urdu, Vietnamese, Albanian, Bengali, Cantonese, Farsi, Hindi, Lithuanian, Mandarin and Pashto. And those languages weren't picked at random. These were picked because these reflected the ethnic backgrounds of the women who were often test positive for hepatitis B in pregnancy. If I could have the next slide, please. And we've also increased our range of primary care resources. So these are resources for healthcare workers, in particular midwives, health visitors, and general practice nurses. So we've got that left-hand image there is a guide for general practice and general practice nurses around hepatitis B. And we felt that was important because the total birth cohort each year in England is about 650 to 700,000 babies each year. only 3,000 of those are born to hepatitis B infected mothers, and we needed to raise the profile of these babies amongst the healthcare workers that will be looking after them following discharge from midwifery services. The other thing that we've done is some resources, and in particular we worked with the Royal College of Nursing around a little webinar for the test at 12 months of age. So there's a heel prick test. It's called DBS, which is direct blood spot. So rather than the practice having to refer baby to a paediatric phlebotomy service in a hospital, the general practice can order these kits from PHE, and they can do their own heel prick test on baby at 12 months of age at the same time as they're getting their 12-month dose of vaccine. And this has been very successful. This has increased compliance with testing, so that we know we have a better insight as to whether or not the program has been successful. And it also allows the GP to understand if the baby is positive, if the vaccine hasn't worked, or if they haven't had sufficient doses at the right time. If you have got a hepatitis B positive baby at the age of 12 months, they can then refer that baby into a specialist paediatric service to get the right care.
So, I mean, I suppose what I noticed most was this the kind of drop in take up for parents, and I kind of in my mind was wondering how we as midwives can improve that, because in a way our kind of care is much earlier than a year, for example.
Yeah, I think the key role there for midwives is helping with the education and the understanding, and that can start before baby is born. So I think when the pregnant woman, if she screens positive for hepatitis B infection in pregnancy, I think that's the right time to make sure that she understands what the implications are for her and her baby. And in particular, if we want to avoid baby acquiring hepatitis B infection perinatally, the importance of the timeliness of all those vaccines and completing the course. The pattern of decreasing uptake is something that we see in other programs, though. So we know that uptake of the first dose of routine vaccination 8 weeks is generally higher than it is at 12 or 16 weeks when they should be coming back for second and third doses generally. So there is often a pattern of declining uptake, but I think it's very, very important to try and avoid that in this program, because these babies have already been exposed to the hepatitis B vaccine, and potentially at birth they have had really quite a substantial exposure to that virus.
I was thinking. I mean, I'm assuming that a lot of these mums are given text messages to remind them. Or is that a bit too techie?
I think it will vary. So it's probably done by letter. But some GP practices do use text messages. I've been bombarded recently with text messages telling me to go and get my flu vaccine because I'm over 50, but I've already had it thanks to PHE. But I think any and all communication methods have their validity in this program. Most of it, I think, will be done by individual letters, but if that can be enhanced with a text message from the practice to the mother, that would be fabulous.
I suppose we have to take on all of this more techie mantle. I mean, I did have one question. From Deborah, and I know we've got Pat coming back. While I've asked the question and she's settling, from Deborah, she's saying, do you think the decline in uptake is down to lack of the explanation and own language information?
I think that could well be part of it, actually. And the hepatitis B is a disease of global concern, and a significant proportion of the cases of hepatitis B that we see in this country are where babies are being born to mothers who either maybe weren't born in this country, and perhaps they're immigrants, or maybe they are the daughters of immigrants. So the language issue, I think, is very, very important indeed, and I think that's reflected in some of the translated leaflets that we've now got. But no, I totally agree. Much of what we need to do to improve compliance with vaccine uptake, I think, is around communications, and that's sometimes communications at handover between different healthcare workers, and we haven't actually mentioned health visitors, because they have an important role in educating and promoting these vaccines as well, but also making sure that we're communicating in a language that the mother of the baby can understand as well.
Yeah, absolutely. Thank you, David. I'm not sure if Pat is back.
Yes, I am back. I do apologise. I have no idea what happened there. Okay, so basically, why was the project needed? So there was a pregnancy, hepatitis B and pregnancy audit done in 2013-14, where Dr. Heather Bailey from the UCL just contacted every trust in the UK and did quite a deep dive into all the cases. So we obviously have standards data as well, which is returns on, the uptake of hepatitis B screening, etc., etc. So all of these things, all of these different things demonstrated an evidence of numerous incidents across the screening and immunisation pathways, including missed screening, obviously, HB, the immunoglobulin not given, lost, not ordered, vaccinations not given, primary care not notified, poor MDT working. And just coming in on exactly the question that was being raised when I came back in was about health inequalities, that this is a vulnerable population, often from ethnic minorities, immigrants, asylum seekers, women with poor English, etc. And there's one of the things that is very obvious with hepatitis B is there's no charitable voice either for hepatitis B. Thank you. So next slide. Thank you. Next slide. Thank you. Hello. Oh, sorry. I do beg your pardon. I thought it was moving on my computer. So really, the project aim really was to enable gold standard care in line with HIV. Now, in maternity services, HIV is now, for want of a better word, mainstream. It's seamless. Everybody knows all about it, and very little goes wrong in it. And we really wanted to try and get hepatitis online with that. So obviously to reduce the incidence. And to enable parents to make informed choices. And again, going back to that conversation that's happened when I came back in, as Sue kindly said in my introduction, I came from a trust that had a really, really good public health team. And when I came into the project, I realised that actually I'm not sure that we did talk to a lot about parents about what happened when going forward, about birth registration and going to the GP, etc. So that was a really big part of the project, was to enable parents to make informed choices, to get better multidisciplinary working, and very importantly, to improve the surveillance of the virus in mothers and babies. Because I think, as you said, that David said, that when we do the surface antigen testing at 12 months, that will tell us whether the baby is infected. What it won't tell us is when that happens, whether that's down to the baby being infected during the pregnancy, at the time of birth, or whether it's vaccine failure. And increasing public awareness and knowledge. Next slide, thank you. So the project work streams really were just to kind of look at the policies and guidelines. Sorry, I've gone to the wrong one. So the project team was massive, as you can see. There was ourselves, the National Infectious Diseases and Pregnancy Screening Programme, the immunisation team, the virus reference department. I've learned so much from a very clever scientist called Dr. Samreen Ujaz. The health protection teams, and obviously we involved clinicians and stakeholders. We have a really fantastic expert group of midwives and nurses who we run everything by. And I just like that little slide that said the agenda for the meeting was to find out why we were having the meeting, when you have so many people around the table. So the work streams really were to look at the policies and guidelines, to look at the pathways. We're on slide 11, sorry, Catherine. To look at the policies and guidelines, to look at the pathways, to look at the gaps in the pathways, obviously to try and look at this surveillance to get a better idea of what the virus is doing. Training and education, of course, is a big part of that, and to roll that out, and obviously communicating the communications around it, and very importantly, the patient information. So what did we do? So next slide, please. So we wrote this tome called the step-by-step guidance. It's about 70 pages, but it is a massive multidisciplinary thing that we all sat down for, well, it took 2 years to write. And it literally is a step-by-step guidance to screening, right down to that 12-month blood test. Information on, obviously, the clinical picture and transmission of hepatitis B, the global elimination strategy, surveillance of the virus, screening and care in pregnancy of women and their babies, women who decline testing, and that's an interesting group because we do have a fairly consistent little group of women who decline testing in certain parts of the country, which is interesting. And at the moment, we're in the process of doing quite a deep dive into that to find out whether that's about a lack of information, about attitudes to testing, etc. Obviously, the immunisation schedule, and there's quite a big piece in there from the Oxford group around dealing with people who decline vaccination as well as testing, and obviously around the mixed vaccinations. So next slide, please. So the pathways, as I said, they look a bit busy, but what I just wanted to demonstrate to you was that what we did was we've got the generic screening pathway, which is obviously just, the routine generic screening pathway, but we took out the hepatitis B bit and we split it into lower and higher infectivity. Because one of the things that came out of the incidents was that there was certainly confusion around that, about women with lower infectivity and women with higher infectivity, who was toward the immunoglobulin, where was it stored, all of that sort of thing. So we took it out and split it all up. And then we've got the neonatal schedule as well. And it's about this joined up working, this collaborative working on the pathways. Next slide, please. So I just grabbed a shot of one of the parts of the pathway just to demonstrate to you what we did was we literally have made it as simple as possible so that every step is explained, and we've split it into actions and information all the way through the pathways. So that's just a really, that one is just a demonstration of what happens on Delivery Suite about the third trimester review. What we've tried to introduce is a lot more with the midwives. Care is a lot more talking about the vaccination schedule, talking about registering the baby with the GP, talking about registering the birth, and the importance of the vaccination schedule. So we've introduced this third trimester review, hopefully, that will all be checked over. So next slide, please. So what did they tell us? That basically the pathways will tell us about who does it, defining the roles and responsibilities, ensuring that seamless handover care, our little relay man here, when that happens, what you need to provide that care and why, the evidence and safety and the standards. Thank you. A little slide on violence surveillance, which I won't go into too much, but this is very important to us as part of the project, is to try and get a grip on what's happening with this virus and is it evolving, is it mutating. So we've introduced this, all women screening positive for hepatitis B will now have a screening sample sent to PHE Colindale, to the Virus Reference Department, at the beginning of the pregnancy, so that Dr. Ijaz and her team can have a good look at it then. But with the higher infectivity only at the moment, we'll then take another sample from the mother at baby and at delivery, just to have a look and see what that virus looks like at that precise moment. And then in with that 12-month sample, we can see, hopefully you can see that we're going to get a really good view of what that virus is doing. Next slide, please. I think David's spoken about the leaflets.
Yep.
Yep, great.
You're straight to 20.
That's lovely. Thank you. So we've done a lot around education. We've got amazing new IDPS, infectious diseases in pregnancy e-learning package coming out. It's probably going to go live at the end of the month. So you need to go to the e-learning for health, which obviously most of you will all be attached to. We also have a screening blog, and that's coming out on Friday, hopefully, which will give all the links to the various resources that we've discussed this morning. We've got had a couple of articles in the RCM magazine around protecting babies and saving lives. So there's a lot of stuff out there, hopefully. So the timescale is that we are literally this week, it's been a busy week, we're going live with everything. And if you go onto gov.uk, look up infectious diseases in pregnancy and hepatitis, it should take you to a collection page which should show you all of those resources on all the links to them. And then for the next couple of months, hopefully the plan is we've asked trusts to review their policies and guidelines, just to have a look and see a kind of a gap analysis and see if there's any particular spaces. I did 18 sessions online last month with screening coordinators and chairs and clinicians. So hopefully that's well. And then on April the 1st, all women screening positive for hepatitis B will commence this improved pathway. Next slide, please. Thank you. So sorry that was all a bit out of order, but I hope you got the message. It's been an amazing piece of work to finish my career on, I have to say, working with such a collaboration and such great people at immunisation and at the virus reference. So and mostly to anything queries is best to go through the screening help desk, because they will direct you to the right people. So that's the PHE screening help desk, and that's anything around the screening programs. And obviously, David and I, that's our contact details. And thank you so much. And sorry for my technical difficulties.
No, thank you very much, Pat. And thank you for coping with the IT issue. It's a major problem, you know, and we rely on this so much. But thank you for dialing in and taking us through those extra slides, and for David, for because I think it came through all the activity and work. It's a massive project. What I would say to the audience is, in the next break, guess what? There's a Meet the Expert session with Pat and David answering questions, and you can get lots of information. I think one of our people who asked a question, Deborah, if you go there, you'll be able to get resources, and they can send that out to you. And I think that new publication looks as though it's going to be a sort of essential kind of Bible for each trust. So thank you for sharing that. It's really helpful.